but I'm glad you came in person. Okay. Okay, so it's recording. Welcome everyone to Year 3 Gastrointestinal Hepatobiliary Lecture. I'm Caroline. It's been a while since I last did a lecture. It's been a while since PS Pirates, but it's good to see you all again. We're going to be unpacking all of the R1 conditions. So these are the ones here, as well as the R1 hepatobiliary conditions. And these are the resources that I used for this presentation and resources I would recommend for your preparation as well. So I've categorized this presentation by symptom. Hopefully you can see. Yeah, you can see it all. So I'm going to be unpacking them in this order as well. It's a lot easier to look at GIT because it's such a heavy subject to look at it in this way and not by symptom in isolation, because a lot of them do present with similar symptoms. In this case, all of these conditions are acute abdomen situations. Some of them involve peritonism, chest pain, vomiting, diarrhea, as well. And then you've got GIT bleed, but obviously, you need to break these down into upper and lower GI bleed, which we will do, and then malabsorption situations, which are more chronic conditions. So the acute abdomen involves these conditions. First of all, for this exam, you should probably be able to recognize or list at least 3 pathologies for each quadrant. And you also need to consider situations where the condition is extra abdominal. For example, like a right lower lobe pneumonia causing right upper quadrant pain. So this is a schema I took from this side. It's also in like the list that I gave before. They have really good resources, and this is one of them. So they've broken down into life-threatening situations we have to think of first. That's like in the ED when we do a primary survey, primary assessment. We want to look for 4 things in particular: obstruction, perforation, vascular issues, and ectopic pregnancies. And the reason why these are all so life-threatening and why we want to care about these first is because if any of these result in the second one, perforation, then that will cause the abdominal contents to leak into the peritoneum, and then that will be infected, and that can lead to sepsis, and that's life-threatening. On the other hand, things that we should be concerned about but aren't as life-threatening are here. We've got liver and biliary pathologies. We've got appendicitis and colitis, diverticulitis and colitis, and then the gastric pathologies as well. Also remember the extra abdominal situations, in particular pneumonia for the right upper quadrant and pyelo or renal calculi. And then when we break it down, this is what we want to do to have a look at differentials. Here's another schema that encapsulates all of the GIT quite well. So to break it down, we've first got rule out respiratory conditions, rule out genitourinary and repro conditions, rule out appendicitis if it is necessary, and then break the rest down into acute and chronic. Chronic is going to be things like peptic ulcer. Under acute, you've got life-threatening, vascular, perforation, obstruction, and ectopic pregnancy, like we discussed. And then an anatomical approach once we've ruled out the life-threatening conditions. So the life-threatening conditions in there, obstruction can be ruled down into SBO and LBO, and then you can organize the following conditions according to its anatomy, its symptoms, or the time. In particular, if something is worse, if pain is worse after eating, then it's a gastric peptic ulcer disease. And then if it's better, it's duodenal, things like that. Okay, so acute abdomen questions. The first one, 22-year-old male presents to the ED with a 24-hour history of abdominal pain, which began around his umbilicus and has since localized to his right lower quadrant. He reports nausea, loss of appetite, and low-grade fever. Physical examination reveals right lower quadrant tenderness, rebound tenderness, and guarding. So this is appendicitis. Which of the following is the most appropriate step in the management of this patient? Feel free to also put it in the chat as well. Just private message me. The answer is immediate appendectomy. The reason why it's immediate is because he's got the symptoms and he's also got rebound tenderness and guarding. So that means it is an obstructive picture. No, not obstructive. It's a perforation picture. And they do have markers of inflammation. So the peritonism signs, involuntary guarding, rebound tenderness, and rigidity. So they need to be in theatre straight away. The reason why it's not something like an ultrasound is because the ultrasound will take too long and doesn't tell us enough. They already have clinical features of appendicitis. We don't need to do an ultrasound. Same goes for CT. We don't really need it because it's quite clear that it's appendicitis. And definitely not pain management because that does not solve the peritonism symptoms. Next question. There's a 32-year-old woman who comes to the ED with a 2-day history of abdo pain and diarrhea, 8 voluminous stools per day, some of which were bloody. She went to an international food festival 3 days ago. She takes no medications, high fever, blood pressure's fine, tender abdomen, bowel sounds, dry mucous membrane. So she's been passing stools to the extent where she's dehydrated. There's some kind of infection in her stools, but it's pending for the culture. What is the most likely? So this question is tapping into whether or not we know about our watery diarrhea versus our bloody diarrhea. And that's something we do need to know about. So I will go through. The answer to this one is E, omelette. So with omelette, with undercooked eggs, that can result in bloody stools. So she's got the fever, leukocytes, blood, and mucus in stool, and it's due to salmonella. On the other hand, reheated rice, that's Bacillus cereus, that is a watery rather than inflammatory diarrhea. Yogurt is Staph aureus, and that's watery. Toxic mushrooms, they should have a lot more symptoms than that because they will have like toxic renal and liver failure after 3 days. And home canned vegetables, that's botulism, and that would not cause inflammatory diarrhea, but you would have things like paralysis and dysphagia and the neurological signs. So in this case, omelette is the right answer. Next question. Here is someone with no history of alcohol consumption but has acute pancreatitis. In this case, we're immediately thinking about what are the causes of, oh, there's a chat. Sorry, I didn't see that. Hey, oh, sorry, you typed in. Okay, I'm gonna have the chat open now, so you can still put answers in. And welcome to those who have joined just now. So, acute pancreatitis is caused by mainly one of 2 things: alcohol or gallstones. If this person doesn't drink alcohol, then it's probably a gallstone situation, and then that is confirmed by some things here. We've got amylase and lipase that are more than 3 times the upper limit of normal. That's one of the criteria. And then we've got bilirubin that is really high. Yeah. And then we get a transabdominal ultrasound revealing gallstones and a really dilated common bile duct. So the question is like, what's the next step? Antibiotics, that's not enough. And now evidence shows that we can't treat cholecystitis with antibiotics just because of the risk of antibiotic resistance. Because if you treat it with antibiotics, then you get like a 60% success rate. But that does mean someone has to be on antibiotics for 10 days. So that's like 30 doses of antibiotics versus actually solving the issue, taking them into theatre, and that means they only need 2 doses of antibiotics afterwards. So we're reducing the amount of antibiotics in the community. So the answer is ERCP and sphincterectomy. They have acute pancreatitis, but not a lot of alcohol consumption. So it's probably going to be a gallstone situation. And then a transabdominal ultrasound is good for identifying gallstones, but less sensitive for distal CVD stones. The key learning point is the most effective way to reduce the complications from acute gallstone pancreatitis is ERCP, and also to take off the sphincter. This is what the procedure looks like. An ERCP is, what's it called again? Endoscopic retrograde creatography. So you take a tube down here and then you remove the gallstone from this angle. And then sometimes that you do acutely, and then maybe a little bit later when they're feeling a lot better, and if they weren't stable before, if they are stable now, we can take out the gallbladder and that solves the problem. Okay, so now we've done some warm-up questions. Let's get into the discussion. So acute abdomen and inflammation can be from a lot of things. It can be infectious or non-infectious, and then we'll go through these conditions later as well. First, pancreatitis. So what are the two main causes of pancreatitis that we discussed? That's alcohol and gallstones. Acute pancreatitis. So the typical manifestations are severe epigastric pain radiating to the back. And remember, this is a differential diagnosis of this is a AAA. So keep that in mind. It also causes nausea, vomiting, epigastric tenderness on palpation. To diagnose it, the lipase and amylase need to be more than 3 times the upper limit. And the sad thing about pancreatitis is we can't fix it, you can't treat it. So what you can do is solve the cause. Like if it's a biliary pancreatitis issue, then do ERCP or cholecystectomy. If it's a hypertriglyceridemia issue, then give them statins or whatever to lower their lipids. But you can't treat the pancreatitis. All you can do is give them the fluids that they need because they've been vomiting for so much. You need 2 large bore IV access. You need to treat their pain. You need to treat their nausea. Sometimes antibiotics, and they might be nil by mouth, but you can't do anything else. The problems with pancreatitis is that it can lead to sepsis, acute respiratory distress syndrome, organ failure, and shock. The reason why it can cause acute respiratory distress syndrome is the circulating pancreatic enzymes can create an inflammatory response. And what else? And pancreatic pseudocysts are situations where it's sterile, but it just walls off the inflammation into like one little bubble in the pancreas. And then the way to treat that is you just have to drain it percutaneously. So here we have the criteria that we talked about, and they do need to do a CT scan as well with contrast. Gastro. So gastro, we can divide into infectious and non-infectious, as well as under infectious, we can divide it into bacterial and viral, as well as like the other things that we don't really need to know about. These are the main ones. The important thing to know about gastro is that children have rotavirus and adults have norovirus. That can be a question. And a lot of the transmission is through the gastrointestinal tract. We don't really take stool samples. Sometimes we might if we want to give antibiotics, or sometimes if we think it might be something abnormal, such as like like worms in travelers and whatever. But in general, we just treat it symptomatically. So remember, norovirus in adults, rotavirus in kids. And we need to differentiate between watery diarrhea and bloody diarrhea. So I'll ask that later. So watery diarrhea, Bacillus cereus from rice, enterotoxigenic E. coli, and Clostridium perfringens, as well as Staph aureus and cholera. Remember, cholera is the one that results in, actually type it in the chat, private message me, what kind of symptom do people with cholera have? What kind of diarrhea? Perfect. Yeah. Anyone else? Okay, yeah, that's right. Rice water stools, and that's a buzzword, so remember that. What are 3 causes of dysentery, bloody diarrhea? C. diff, yeah, C. diff is one of them. This one's a little bit hard. So the other one we talked about was omelette. So what's that called again? Salmonella. The other ones, yes, Shigella. So Campylobacter, that's in people who like drink water that's been contaminated by animals and stuff. And enterohemorrhagic E. coli, undercooked meat, C. diff in antibiotic users, Shigella as well as salmonella. Okay, GORD. GORD is a gastroesophageal reflux disease, and some of the causes or risk factors are obesity, stress, eating habits, like people who lie down after meals, and anatomical changes like hiatal hernias. The reason why obesity is a risk factor is because of the increased abdominal pressure, as well as people with obesity also are more likely to have problems with the lower sphincter. So, lower sphincter in the esophagus. So typical symptoms are buzzwordy, retrosternal burning pain, as well as regurgitation. And we need to treat them with something that will stop the acid. So proton pump inhibitor. I remember being really tripped up with differentiating between GORD and peptic ulcer disease management. Can anyone put in the chat what is the difference between these two? Because it's essentially like similar symptoms. You've got like pain in the same area, but what changes? The difference is in GORD, you need a proton pump inhibitor, but then in peptic ulcer disease, you need this. If it's for H. pylori, you need omeprazole, amoxicillin, and clarithromycin. So remember, this is for treating an infection, whereas this is not an infection. This is just a problem with the sphincter causing the backflow of acid into the esophagus. So to treat this, we have lifestyle modifications, medications, and surgery sometimes. Complications are that GORD leads to Barrett's, and Barrett's can lead to adenocarcinoma. That's really important. It will probably come up in the exam. So we've got stratified squamous in the normal esophagus and simple columnar in Barrett's esophagus. The issue is that you want to treat it when it's in this stage. So the symptomatic and it's starting to damage, but we haven't reached columnar epithelium yet. So what happens and how do we treat GORD? So what we need to do is firstly identify if there are any alarm symptoms. So in GORD, sometimes if they present with dysphagia or odonophagia, which is like difficulties eating and drinking, that might be an issue with like a cancer in the esophagus or even like a gastric carcinoma. So rule out the cancers, rule out the unintentional weight loss, things like that. Rule out the cardiovascular causes, rule out the ENT causes. Then we get down to Barrett's. And if someone is at risk of Barrett's, we need to give them PPI, as well as sometimes if they've already got the complications, so the strictures and the Schatzi rings, then we might have to consider giving them surgery. Peptic ulcer disease. How do you tell the difference between a gastric versus duodenal ulcer? So we talked about this before. If it's here, then when they have food, the acid and the food and the exposed ulcer will cause pain. But if it is better after food, then it's here because when they're eating, the sphincter here closes. So all the acid is not going into here, but it's staying in here. And then that means the duodenal ulcer gets better. So as you can anticipate, people who have a duodenal ulcer might be predisposed to gaining weight because eating physically makes them feel really good and makes them take away the pain. So weight loss and weight gain, that's something to tell the difference. Otherwise, the symptoms here are really similar. They'll have a positive blood sample in their stools. It'll feel better with antacids. They'll have dyspepsia. What are the 3 drugs to manage a H. pylori infection? That's omeprazole, amoxicillin, and clarithromycin. That's something we do need to know, as well as other things to treat it would be to fix whatever's causing it. So stress, hypersecretory states, NSAIDs to stop and manage the H. pylori infection. A typical symptom would be epigastric pain, though some patients are asymptomatic. And with proton pump inhibitors, we continue them for 4 to 8 weeks. And then we might have to reconsider maintenance therapy, which means like re-prescribing a PPI for them again. So this was a bit of a gag because it's kind of hard, but what are the differential diagnoses in this picture? Feel free to put it in the chat. To orient you, we're looking at it from the feet up. So this is the right side. I've got arrows pointing to some things. So there are some pathologies going on. There's a situation here. So right side, it looks really inflamed. There's like fat stranding here. And then the black arrow is around hyperdense lesion at the proximal end of the appendiceal lumen. It is appendicitis. And like these are the features that indicate a perforated appendix, secondary to appendicitis due to fecalith. So appendicitis is inflammation of the appendix. Sometimes it's because of fecalith, so like a tiny piece of stool has like clogged up the appendix. Sometimes it's just because of the bacteria that we have in our gut and it causes inflammation. So characteristic features are the periumbilical next to the umbilicus, migrating to the right lower quadrant. They'll also have anorexia, nausea, fever, and right lower quadrant tenderness. And we have to treat it with an appendectomy. So if it's not perforated, we can either do it open or laparoscopically, plus minus some antibiotics as well, gentamicin, metronidazole to cover the anaerobes and amoxicillin, ampicillin. If it's already perforated and they're unstable, we need to take them into the theatre immediately and we need to wash it out. And if they're stable, then we might start with antibiotic management first, drainage, but we need to do surgery whenever it's life-threatening, whenever they're at risk of sepsis. On the topic of sepsis, acute peritonitis is next. So there are mainly infectious conditions that cause it. We won't go into this too much because this is outside of 3B scope, in my opinion, but it's more, we're going to be talking about issues with spontaneous as well as, I think that's it mainly. And then a cause of peritonitis is bowel perforation. Something has burst and you've got gastric contents in the peritoneum. That comes from diverticulitis, appendicitis, Crohn's, cancer, peptic ulcer when those perforate, volvulus, hernia, stricture, all of these. So acute peritonitis it also encapsulates or also involves SBP, spontaneous bacterial peritonitis. So it's a bacterial infection of acidic fluid without an identifiable intra-abdominal source of infection. Most commonly, it happens in people with cirrhosis, and this one is pretty intuitive. With the cirrhosis, you've got ascites, and like I'll talk about that later in the liver cirrhosis topic. But with the ascites, you've got like fluid sitting in the peritoneum. It's most likely going to catch some sort of infection and then cause havoc inside the abdomen. So common pathogens are gram-negative bacteria, but now increasingly gram-positive. I suspect that's probably got to do with, it actually says, never mind, multi-drug resistant bacteria. And clinical manifestations, we've got peritonism signs, so fever, abdo pain, sometimes even altered mental status because of the inflammation, sometimes because of hypotension, or like the sepsis can cause people to lose consciousness. Diagnosis, neutrophil count from the acidic tap. So we tap them, take out the fluid, and we have a look at it, also look at the proteins, look at what we can culture from the tap. And to treat, if it's a perforated viscus, for example, if it's a peptic ulcer that has perforated, give them IV omeprazole. If it's another organ, then we give them metronidazole and amoxicillin, and we treat them for surgery. If it's spontaneous, like nothing has perforated, but they still have the peritonism signs, then we need to treat it with empirical ceftriaxone. If they have renal impairment, we give them IV albumin because IV albumin keeps the water inside our blood. So obviously, like for example, with cirrhosis and people don't have albumin, then you lose water through third spacing, you lose it out of your tissues into the peritoneum. So people with renal impairment can't afford this because their kidneys are already damaged. So we need to protect the kidneys by protecting the amount of blood that's inside the vasculature. And to do that, we give people albumin, and that means that their kidneys can be well perfused. We also can do some prevention for like further damage in cirrhosis patients with trimethoprim and sulfamethoxazole. Bowel obstruction. So bowel obstruction, lots of things can happen to it, but to break it down into two main groups, it's a nerve issue, and that's called paralytic ileus. Paralytic ileus happens in people who have had surgeries in the bowel, and sometimes their nerves are a little bit damaged. On the other hand, there's a plumbing issue. So that's when we have a mechanical bowel obstruction. There is something physically in the bowels that's stopping the contents from passing through. So the causes of SBO, or small bowel obstructions, are most likely post-operative bowel adhesions. And the causes for large bowel obstructions are things like colorectal cancer and colon cancer. So the symptoms: nausea and vomiting because you've got blockages. So when people continue to eat, they will feel sick and then vomit that food out. Abdomen pain and distension. Well, it's like if you've got a small bowel obstruction and you've got a blockage there and you continue to eat, then you're going to get people are going to get a distended abdomen. Constipation, which is blockage of stools, and obstipation, which is blockage of stools and gas. So if someone has obstipation, their condition is really severe because it's to the point where not only can like solids not pass, but gas can't even pass. That's why we ask people, have they passed gas in a GIT history? Earlier stages, you're going to have increased high-pitched bowel sounds. That's because the tummy is making up for the obstruction and by increasing the amount of peristalsis. But over time, you'll have decreased or absent bowel sounds. And bowel distension can also lead to third space volume loss, dehydration, electrolyte abnormalities. It can make people really, really sick. What is a cause for extrinsic and intrinsic bowel obstruction? So give this one a go, put it in the chat. It means what is a cause of bowel obstruction from the outside of the bowels, pushing in, or sometimes within the bowel wall, and what's a different cause for bowel obstruction from inside the abdomen, inside the bowel lumen. Would adhesions count for extrinsic? Wait. Sometimes it can be extrinsic, but it can also be intrinsic too. But that's a good one. So definitely adhesions. Let's see what this, oh yeah, adhesions are extrinsic in here. And then if it's inside, they call them strictures, and that's in IBD. So extrinsic. Sometimes there's volvulus, so that's the twisting of the bowel. I have a picture of it later. Hernias and intra-abdominal masses pushing the bowel together. And if it's inside the bowel, there are tumors, diverticulitis. In babies, you have intussusception. That's when, you don't have to know it now, so you can just cover that next year. And fecal impaction for children who are extremely constipated. So bowel obstruction, to diagnose, you probably need imaging. And on abdo X-ray or CT, you'll see dilated bowel loops proximal to the obstruction, collapse of distal bowel loops, and multiple air fluid levels. This makes sense. So you've got an obstruction. Say there's an obstruction. Before the obstruction, there's going to be like lots of food staying there, so dilated before, and then after that, then the bowel is empty, so it's going to be collapsed. To manage non-operatively, we need to let the bowels rest. So sometimes that involves putting an NGT, nasogastric tube, down, sucking up all of the contents from the tummy and the stomach, letting the bowel rest, putting them nil by mouth, and then just like supporting them with IV fluids, analgesics, antiemetics, and antibiotics if they need. but sometimes for surgeries, like that's required if it's like severe. Most of the time, it's a small bowel obstruction, simply because the small bowel is a lot smaller in diameter. The large bowel is quite large. And that also means, unfortunately, a lot of the cancers in the large bowel like take longer to diagnose because people can have a cancer and then they don't experience the constipation or obstipation until it's basically grown to a size that is unmanageable. What is the name of this sign and what is the pathology? This, I feel like this came up in my year, so give this one a go. Perfect. Sigmoid volvulus. And can you name what the sign is? What does it look like? Coffee bean sign. Amazing. Coffee bean here. So there's markedly dilated bowel that's in green, and it extends obliquely from the right upper pelvis into the left upper abdomen. And then the red overlay is the double wall thickness of the two bowel loops. This is a coffee bean sign. And this is a small bowel obstruction. So you can see multiple fluid levels here, here, here. And you can't see haustra, which looks like that. So this is a small bowel obstruction, and this is a large bowel obstruction. There's the haustra as well. Okay, so what do we do with a bowel obstruction? We need to get rid of whatever is backing up into the GIT. So take it out with an NG tube, give them fluids, support them with analgesia and antiemetics. If they've got a fever or some kind of perforation, if they're perforated, they probably would have to go into theater, but sometimes antibiotics. And then someone can, if they can tolerate a CT, then do a CT. If they can't, then an abdo X-ray. Intestinal ischemia. This one is kind of interesting and also really serious. So what can happen is we've got arteries that are supplying the colon, and people who have AFib, for example, where are the risk factors? Do I have risk factors? Things like atherosclerosis or severe hypotension can result in people having like blockages to the arteries that are supplying the gastrointestinal tract. So acutely is an emergency because someone will present with sudden severe abdo pain because the colon is not getting the blood that they need. And the colon is not that like resistant. And if it doesn't get blood, I think, I know for kids, it's like after 6 hours and you lose the bowel forever. And then the only option is like to take it out. So it's really serious. Someone like, so if someone presents with this, they need to go into ED straight away. On the other hand, with chronic mesenteric ischemia, sometimes people have had problems with these issues for a long time, and then their bowel is just slowly dying. And then ischemic colitis is cramping abdominal pain with bloody diarrhea. It usually is self-limited, but can progress to fulminant bowel necrosis. How do we treat? If it's acute mesenteric ischemia, we need a search review and to revascularize that area. Mortality rate is really high, as you can imagine, because if you have death or necrosis of these areas, and I'll explain to you why, we'll talk about why these areas in particular later, but if you've got tissue dying here, then it's going to likely perforate, and then you exposing the peritoneum to all of the bacteria that's inside the large intestine. For CMIs, we needed to revascularize as well, and then colon ischemia, primarily with supportive care or monitoring for symptom progression. Some causes. So arterial is most common, thrombosis, embolism, atherosclerosis. Watershed areas. So watershed areas are areas where you've got two main arteries supplying one spot. And ironically or paradoxically, even though it's got supply from two areas, because it's also supplied by the two smallest arteries from each branch, it can cause an issue when we have people with hypotension or people with atherosclerosis or some kind of clot from either like a cholesterol stone or platelet that blocks up the arteries, and the large intestine is not supplied by the blood. The main two watershed areas are the splenic flexure and the rectosigmoid junction. Diverticulitis. So diverticulitis, here's a picture of it. You've got a lot of swelling, a lot of this, I believe, is a picture of it already perforated. So diverticulitis comes from diverticulosis. Diverticulosis is just a condition that normally doesn't present with any symptoms. It's just an outpouching. See if I've got a picture. It's just a simple outpouching of the bowel. Usually it's from constipation or chronic constipation. And then a lot of like the stretching here has caused a little outpouching. Sometimes it's genetic, I believe, as well. And then so you've also got like Meckel's diverticulum, which people are born with. But diverticulosis shouldn't be an issue. It's only an issue when it gets infected or inflamed or if it perforates. So it's typically asymptomatic. Sometimes people have abdominal discomfort, and sometimes when it's irritated, it can bleed. That's a concern, obviously. But sometimes you get like painless diverticular bleed, and that is a buzzword. And to diagnose it, you can diagnose it with colonoscopy for people with symptoms. Or the issue is if it's acutely inflamed, if they have diverticulitis, then a colonoscopy is contraindicated because you don't want to be sticking up a camera and then spreading that infection anywhere else. Diverticulitis is the complicated version of diverticulosis. In this case, we've got either uncomplicated diverticulitis or complicated. This is just when it stays in its pouch, it's causing pain, it's causing fever, but it's like localized. Here is where it has caused an abscess. Sometimes it's perforated and this person needs to go into theater. Symptoms are like infection or inflammation symptoms, left lower quadrant pain. It's often in the left lower quadrant because people with constipation normally have it like fecal impaction up to here. You're not going to really see it across the entire large intestine. And surgical recommendations, yeah, a colectomy, take it out, and then you solve the problem. So remember the main differences are this causes diverticular bleeding. This is painless bleed. Diverticulitis doesn't cause bleeding. So I think I was confused with this last year. It's rarely hematochezia because this is infection, inflammation, more issue, and this is like the bleed. Here are the things that can happen. Yeah, fistulas, also in like IBD as well, abscess, perforation. These are like pretty serious issues. What do we do with diverticulitis? So if they do not meet the criteria to be admitted, that's fine. Just treat them with analgesia and a liquid diet. Sometimes if it's really, really severe, they need surgery. If it's sort of in the middle, what do? You can either drain it percutaneously by the skin or give them antibiotics, fluids, analgesia, and nil by mouth. And then what else? Yeah. And then either like you can evaluate them for surgery later or also like give them suggestions to have more fiber and change their diet and whatever, and treat the underlying cause as well. Chest pain. So I don't have anything for chest pain. This is just the conditions that we've talked about before: acute pancreatitis, GORD, and PUD. Remember, there's also like other like pneumonia and stuff like that. Vomiting. So we've talked about acute pancreatitis, we've talked about gastroenteritis, obstruction and ischemia. All of these can cause vomiting. The link between ischemia and vomiting is that ischemia causes like damage to the bowels, and sometimes that like can reduce peristalsis, and then that can cause sometimes obstruction. I believe that's the link. And then obstruction causes like the backup of bile or food inside the intestines, and that leads to vomiting. How to approach nausea and vomiting. So here's another schema that I think is quite helpful. So you've got nausea and vomiting. Rule out some of the localizing symptoms. Is it a raised intracranial pressure issue? Is it a benign positional, what is it again? Benign paroxysmal positional vertigo? Is it a RESP issue? Is it an eye issue? Once you've ruled those out, does it fluctuate, especially with food or with peristalsis? And then is it like low grade or is it intense? So how to treat the following. So with acute pancreatitis, we said do an abdo CT with contrast, and we're looking for these features. I think I got like acute pancreatitis in my OSCE, and then what they were looking for was they said one of the questions was, what are the signs you're looking for on CT? I think it was like diverticulitis or pancreatitis. And then they wanted to hear, edema, pericranial pancreatic fat stranding, and gallstones, if it's there. Gastroenteritis, symptomatic, plus minus antibiotics, and intestinal obstruction, do an abdo x-ray, and then solve it like we discussed before. Diarrhea. We've done this. So now we'll talk about these two. No, we've done this as well. So we'll just talk about IBD. So chronic diarrhea could either be non-inflammatory or inflammatory. Inflammatory is like IBD in cancer. And then non-inflammatory are things like lactase intolerance and celiac disease and antibiotics and other things like that. An approach to diarrhea is it a storage issue? Is it acute or chronic? Acute, has it been caused by medications, serotonin syndromes, or even like party drugs, music festival drugs, infections, necrosis, and toxins? Then we've got inflammatory issues, IBD, and then non-inflammatory issues like we talked about, like celiac disease. Diarrhea questions. So there's a 30-year-old female with a history of Crohn's disease and a mild flare-up. According to the Australian guidelines, what do we need to do for this person? So this person has a mild flare-up. They probably don't need surgery. Biologic therapy is really expensive. They probably don't need that first line. That's also not even first line. Antibiotic therapy is not how we treat IBD. So it's C. So the step-up approach is start with aminosalicylates or corticosteroids and then move up wherever necessary. Next question. There's a 26-year-old man, so he's young, in the ED with 2 weeks of worsening bloody diarrhea, abdo pain, and fatigue. He reports passing more than 6 bloody stools per day, and he has a 6-month history of intermittent diarrhea and has lost 5 kilograms unintentionally. So potentially cancer, given how long it's been, potentially IBD. He has no significant medical history, takes no regular medications. Pulse rate's fine, a little bit high. Blood pressure, fine. Respirate, a little bit high. Temperature, high. Pale conjunctiva. So he's lost a lot of blood to the point he's anemic potentially. Soft, non-distended abdomen. So, okay, it's not something that's been perforated. Moderate tenderness in the lower quadrants bilaterally. Amongst various investigations, a colonoscopy is arranged, and here's what his descending colon looks like. So what is the next step in his management? C. Good try. It's B. So intravenous corticosteroids. The reason why C is not an answer is because ceftriaxone and metronidazole are used for things like diverticulitis, but we need steroids for IBD. Really good guess though. The major learning points are intravenous corticosteroids are first-line treatment for severe ulcerative colitis, and it's characterized by continuous diffuse mucosal inflammation, which spreads retrograde beginning at the rectum. So that's why like surgery is an option for ulcerative colitis, but is less of an option for Crohn's because it just happens everywhere. Endoscopic findings of UC include ulceration, friability, and loss of vascular markings. So we are actually halfway through. So I'll give everyone a 5-minute break. We'll come back in 5 minutes. Oh my God. I've been speaking for 3 minutes on mute. Traumatizing. That's horrific. I'll just go back. Okay, that's okay. Thanks for letting me know. I am traumatized by that. Okay, anyway, so it's all good. It's all good. So there's Crohn's and there's UC. So the way we treat it is different. In Crohn's, it's with prednisolone, then hydrocortisone, and then monoclonal antibodies. And then in ulcerative colitis, it's mesalazine, then azathioprine, and monoclonal antibodies. The symptoms are relatively similar in that there's diarrhea, weight loss, abdo pain. The main differences is that Crohn's has extra intestinal manifestations, especially through like the eyes, the joints, and the skin. So in the eyes, it's uveitis, joints, arthritis, and skin like random rashes. Whereas like ulcerative colitis has like not those symptoms. And then I was talking about the severity of the disease. So one way that I remember that it's Crohn's and not ulcerative colitis, like how do I differentiate between the two in my mind, is that Pete Davidson has Crohn's disease. And like there's that video, and the whole point is like it's really debilitating. And like he talks about how debilitating it is. And like I remember, okay, the one that Pete Davidson has is like the worst one to have, and that's Crohn's. And then the worst is like it's also worse because of the transmural inflammation. So it goes through deeper, whereas ulcerative colitis is submucosal, and it also results in fistulas. Sometimes it is between the bowel, and sometimes it's like from the bowel into the skin, which is really bad. And then therefore, like that's why it's like significantly bad. Whereas ulcerative colitis, probably like the worst part about this is that it's got bloody diarrhea, although this can be bloody as well. Oh, yeah. And then like a random, remember that PSC is associated with ulcerative colitis. I think I've seen that in some questions as well. And then that's from faculty. Okay, so that was Crohn's. Let me see. So let me see if I've missed anything. Oh, yes. These are also buzzwords too. So skip lesions, cobblestone appearances, as well in Crohn's. And then ulcerative colitis is friable mucosa, it's superficial, and there are ulcerations. Both of them are associated with bowel cancer. Okay, malabsorption. So there's IBD that we talked about, and obviously that can result in malabsorption because the large intestine is damaged. So you're not absorbing the nutrients you need. And the other one is chronic pancreatitis. So malabsorption questions. If someone has pancreatitis and they've got the symptoms of steatorrhea and weight loss, what is the recommended management for the pancreatic exocrine insufficiency? What do you think it is? So do we give them more fiber? Do we replace the pancreatic enzymes? Do we give them antibiotics, or do we operate? B, perfect. That's right. It's PERT. So we just have to replace what they've lost. Chronic pancreatitis. This is an R2 condition. I've only included it because it seems it's like relevant to acute pancreatitis. The main thing is that you can have exocrines. So that's the symptoms of pancreatic insufficiency, such as fatty stools and weight loss, but you can also have it relate to pancreatic diabetes. The unfortunate thing is to manage it, we can only replace the enzyme therapy. We can't do anything else. And then we just do symptomatic and lifestyle management as well. Chronic pancreatitis results in nausea and vomiting, like acute here as well. It's just the chronic weight loss as well. And I talked before about pseudocysts, so that's what it looks like. It's like walling in the inflammation, and in here it's supposed to be sterile. You can also get calcification of the pancreas if it's like happens for a really long time, atrophy, fibrosis, and these are the changes you can see on CT. Okay, GI bleed. So we talked about ulcerative colitis and Crohn's. We've talked about peptic ulcers that causes bleed, diverticulosis causes painless bleeding. Now we've got to unpack colorectal cancer and hemorrhoids. So let's start with some questions. Colorectal cancer, how often do we need to screen them, or what do we need to do? Colonoscopy every 10 years, an FOBT every 2 years, a CT every 5 years, or a flexi-sig every 5 years? B again. Yeah, perfect. These questions are pretty breezy, but they do indicate that like if you are getting these right, you probably will pass. So well done, everyone. B is the correct answer. Next one, 12 hours of rectal bleeding. So it's acute, bright red blood, large intestine, filling with clots. So it's the amount is so large that it's clotting in the toilet, but is normally in good health. Okay, so it's probably not like Crohn's, given like no past medical history. Back pain, and he's taking NSAIDs for this. It's pale, really low blood pressure, tachycardia. On DRE, fresh blood and clots, so it's still happening. IV has started, and after that, blood pressure was a little bit better, but not enough. Hemoglobin, so he's lost a lot of blood. Which one is the most appropriate step in the management? Good guess. The reason why we wouldn't do a colonoscopy is because they're really ill, and a colonoscopy is like not something that can fix the issue. So when you have someone who's like unstable, for example, like a perforated gallbladder, you take them into theatre because you can do something in theatre to fix the problem. I get the picture what like you want to maybe do a colonoscopy to have a look at what the issue is, but it's like not therapeutic. What tells us like a bit of a better picture is CT angiogram. So actually, no, I'm realizing now like that's also not therapeutic either. Never mind. But the whole point is a CT angiogram can tell us where the bleed is. And this case, it's most likely a diverticulosis bleed. He's like a really old man. He doesn't have any other symptoms. And like this is the preferred investigations for that. Yeah, because he's got this painless hematochezia, signs of anemia, and severe and ongoing drop in hemoglobin. Okay. A man with chronic constipation presents with prolapsed hemorrhoids. What is the recommended treatment option for prolapsed hemorrhoids that have not responded to conservative treatment? So the conservative treatment is like sitz baths and high fiber diet. The answer is B, rubber band ligation. So if it hasn't been solved from the creams, with the steroid creams or whatever, then they need to tie a rubber band around the hemorrhoid, and then that cuts off its blood supply and then causes it to shrink and to fall off. So colorectal cancer. The colorectal cancer is like something we do have to know quite in depth. Essentially, what happens is someone will present with like maybe they're in their 50s, 60s, 70s. Sometimes their parents have had it. Colorectal cancer is one of those things where like if your parent had it at a young age, then you're almost definitely going to get it. And it's like a thing that, yeah, like the genetics of it is like spread quite severely and results in bowel changes, lower GI bleed, and weight loss. And that's like from the cancer. Iron deficiency anemia in men that are older than 50 and postmenopausal women are red flags. Men older than 50 are more likely to get the buildup of iron, hemochromatosis. And like postmenopausal women shouldn't be losing their iron from their menstruation anymore. So those are the two main signs. To diagnose, we need to do like the FOBT first and then colonoscopy. And then the apple core sign is this. So the colon cancer is here. and here, I think. Okay, rectal cancer. So how do we manage? If it's in the rectum, we locally excise it, sometimes using radiotherapy, and sometimes we give them chemotherapy beforehand to shrink the cancer before we take it out. And then colon cancer is the same as well. So just take it out. Diverticulosis. We talked about it already, diverticulitis and hemorrhoids. So I've got two pictures here. One of them is like a low-grade hemorrhoid and one of them is a high-grade hemorrhoid. You can see the difference is that if someone presented to you in the ED or GP clinic with the first one, it looks like you can put it back in. And sometimes the patient might tell you like, oh yeah, it's kind of in the way sometimes, I just put it back in. Whereas the second one, the one below, it is severe. You've got several bits of mucosa exposed. There's like active bleeding from it. You can see the blood there. So that's like, this is grade 4 and this is grade 1. So symptoms, it's asymptomatic or can present as a painless perianal mass. It can be really itchy, and sometimes you can have hematochezia because it's like been the friction from defecation. Risk factors include excessive straining as well as increased abdominal pressure. It's also for people who like spend a lot of the time sitting. Like, yeah, especially like you, I don't know, you might get a question like a year 12 student who's like studying a lot, like gets hemorrhoids. It's terrible. And they are painful if they are below, let's see, I've got a picture. Yeah. So the dentate line is here. If it's before, then it's fine. It's not painful. It's like more painful when it's out here. Diagnosis is on DRE and an anoscopy. Management includes increased fiber, increased fluids, increased activity, and reduced straining during defecation. Sometimes we need to soften the stools. Sometimes we need to give them topical creams like lignocaine, I believe, or like some steroid creams, something to make the vessels smaller, because that's the issue with hemorrhoids. It's the engorgement of the vasculature here. And then if there is a blood clot, then it'll be painful and be bluish purple. So sometimes we just need to cut it out surgically. So what do? We need to give them sits, but this is like the conservative. If that doesn't work, we need to, that's what the question said. So the rubber band ligation, tie a rubber band around it, block the blood supplies, and it'll just fall off on its own. Otherwise, we need to take it into surgery and then block the blood vessels that are supplying the hemorrhoid. Constipation. So we've covered these two. We haven't covered hernias yet. So constipation, also on the wards, like a quick note, you might see polyethylene glycol. That is the best initial treatment, and that's an osmotic laxative, which means it draws water into the lumen. And then senna, which you see on the walls, like docusate and senna, that's different. That secretes electrolytes into the lumen, and then water will follow with it. The problem with this is like these is like it can cause diarrhea. Constipation questions. So, this is actually not constipation. This is just related conditions. A 60-year-old male with minimally symptomatic inguinal hernia. What is the guideline for the management for this patient? B, watchful waiting. Perfect. So the reason why it's watchful waiting is because it's a minimally symptomatic. There's no signs of strangulated hernia. So we can just, watch and wait. The next one, we've got a right-sided lower abdo pain for 8 weeks in a 37-year-old woman. The patient has had increased pain during walking and standing. She's no vomiting, no nausea, no fever. Vital signs are fine. Abdomen soft and non-tender. There's a non-pulsatile palpable groin protrusion above the inguinal ligament. lateral to the inferior epigastric artery, and it's felt during the Valsalva maneuver. Well, what do you think this one is? This one's a little bit harder, but we'll talk about it. Is it F? It's D. So good try. It's either D or F. So you gave it a good go. The difference between these two is, oh, it's actually too many words here. You can read this. I'll just show you the easier one to go through, which is here. So the main difference between direct and indirect is the direct is medial to the epigastric vasculature, and the indirect is lateral. Medial, because if it is here, it has passed through the fascia. Whereas if it's down here, it's because there was a problem with the processus vaginalis. So this, if it's here, it's more an issue of like raised intra-abdominal pressure, and that's medial. And if it's lateral, it's like a problem with fetal development and the process vaginalis, which is supposed to stop bowel from coming down here. So the answer was always going to be one of these two. For a direct inguinal hernia, it's within the Hasselbalch triangle, and this is lateral to the Hasselbalch, outside that Hasselbalch triangle. So those are the main parts to remember. Yeah, the transversalis fascia is the bit that is supposed to cover right here. So I'll go back a bit, go back to hernias. So abdominal, it's through a congenital defect, like the processus vaginalis, and sometimes it's through an acquired defect. So we classify it by location or presentation. This is really important because if it's strangulated or obstructed, then that's more of an emergency compared to if it's reducible. So here is what it looks like. This is what a strangulated hernia looks like. And the reason why we're so worried about it is there's actually multiple reasons. One, the bowel is stuck there, so it's obstructed. So whatever food the person is eating, it is backing up, and that's causing obstruction. And like we talked about before, small bowel obstruction, that can cause perforation, that can like lead to aspiration of gastric contents. Like it's a terrible picture. But also on the topic of like mesenteric ischemia, we're squeezing the blood vessels that are supposed to be supplying blood to the bowel. So that can result in necrosis, which is really ugly and can result in lost bowel. On the other hand, a groin hernia is just one of the types of the hernias. So you've got indirect and direct, as we talked about, uncomplicated or complicated. And then the management is surgery. That's the only definitive management. You might have seen if you've done a gen surge rotation, what they do is they open up these layers, they expose this bowel, they put it back in, then they put a piece of mesh right underneath here, sew it, and then sew the skin back together. The issue is that like they're trying to solve a hernia by going in and putting it back, but in the process of doing another abdomen surgery, they are going to create new adhesions. And so like in the process of solving a hernia, it can result in bowel obstructions in the future. It's really terrible. Like people get like several of them. It's almost, I think what one surgeon said, like it's almost definitely going to like reoccur again. It's just more like for now, we just have to treat it. So it's pretty bad. Okay, so now we're done with gastrointestinal. Let's move on to liver pathologies. The most important ones here are going to be liver cirrhosis, and then by attachment, like these are related to it, as well as and then later the hepatobiliary things. So jaundice. Jaundice, we have like, yeah, you can go through this. This is like a way to look at jaundice. So there's someone who is concerned about hepatitis B exposure, and they ask about prevention. According to the Australian guidelines, what is the most effective way to prevent Hep B? B, vaccination. Perfect. So Hep B and Hep A are things we have vaccinations for. 61-year-old male presents to the ED with 2-hour history of vomiting blood. He's confused, unable to provide a clear history. Vomited blood 4 to 5 times over this period. Has refused endoscopes in the past. 60 units of alcohol per week and 15 cigarettes daily. So, and he has a high heart rate, low blood pressure, jaundice, splenomegaly, and multiple spider nevi. What do you think he has? Or what do you think he needs? Is this esophageal varices? Yes, it is. Well done. So vomited bright red blood. This means he's got liver cirrhosis. So he's probably going to go into ICU if this gets worse. Oh, I'm giving you the answer. Anyway, the whole point is it's terlipressin. That's going to that's going to constrict the arteries and then manage the esophageal varices. The reason why like we don't give propranolol, like that's to reduce heart contractility. That's not going to really solve the issue of the varices. Same here. This is to clot, but we wanted to like that kind of, but like that's later, like after. Statin, that's not going to solve the problem. And then, yeah. Okay, I'm going to keep moving on, but you can do these later. So hepatitis A is like in travelers or like it's through the fecal oral route. It's also in like some countries with food and water hygiene. We do have a vaccine for this. We also have a vaccine for Hep B. Hep B, like a lot of like third-year focus is about this situation. So just familiarize yourself with that. If someone has an surface antigen, what does that mean? If they have that, what does that mean? There is prophylactic immunization, and there's also post-exposure prophylaxis as well. Hep C, same transmission patterns as Hep B. This can develop into chronic hepatitis C. Also, the other thing is like Hep B, once you get it, you have it for life, and you can, although you can have low levels of Hep B, you still have it. Hep C, there's going to be counseling, general management, vaccinate against the other hepatitis, hepatitis, and antiviral therapy. Okay, liver cirrhosis. This is my favorite topic. I think this one is like the easiest to understand, as well as like it involves a lot of pathophys, but once you get it, it's like it's quite good. And like we're going to see a lot of this in practice as well. So liver cirrhosis happens through several channels. You've got alcohol and then alcoholic hepatitis in that kind of picture. You also have non-alcoholic. Interestingly, though, from path, you can remember that non-alcoholic and alcoholic liver like still looks the same. There's like the steatosis and fibrosis and whatever. And then we do have to counsel patients that, especially like in an OSCE, we can have to counsel patients that once they have steatosis, then it is reversible because the liver is really great at regenerating and it's really good at like fighting back. But if people, that only happens if people stop drinking. And if you continue to drink, then you will get liver cirrhosis. You may get liver cirrhosis. I think that's irreversible. The symptoms are ascites. This is from albumin. So to recap, as we talked about, the liver is damaged. So it's not producing albumin. And then albumin is a protein that keeps water inside the blood vessels. So without albumin in the blood vessels, water is leaking out through third spacing out of tissues, out of things into the peritoneum, causing ascites. And if we link this back to acute peritonitis, it's all good. See you later. Thanks for staying. If we link cirrhosis back to peritonitis, then the water that's stuck in the peritoneum can get infected, and then that can cause peritonism symptoms. Hepatosplenomegaly, so with the liver damage, then a lot of the blood cells go back into the spleen, as well as just like an inflamed liver is going to swell. Skin manifestations, we have jaundice, so like issues with bilirubin, spider angioma, that's from like high estrogen, and this is from inflammation as well. High estrogen here. And then complications, so the liver can't break down its toxins, so it builds up and then it causes brain damage, as well as hepatorenal syndrome. So that's when we have vasodilation. And then with vasodilation, the blood pressure drops, and then the renin-angiotensin, whatever the RAAS system, causes constriction of the arteries going into the kidneys. So reduced blood going into the kidneys, and then that causes hepatorenal syndrome. So that's what that is. Lab findings. So elevated liver enzymes, hyperbilirubinemia, imaging, you've got a shrunken heterogeneous liver parenchyma with a nodular surface. Remember also that at the start, it's going to swell up, and then after that, it's going to fibrose and be smaller. Liver cirrhosis makes people really sick. And one of the other complications of liver cirrhosis is caput medusae and esophageal varices, and even anorectal varices, as we talked about before. And I'll talk about that under portal hypertension. We also have, so these are like the estrogen things, estrogen, gynecomastia, ascites we talked about here, estrogen, edema and ascites are linked together just from the swelling. This is from the alcohol consumption. Yeah. Okay, so there's a Child-Pugh score, and that helps us classify how severe someone's liver cirrhosis is. And they've classified it like this, but an easier way to remember it is A, B, C, D, E. A, B, clotting time for C, clotting, D, distension, and then E, encephalopathy. And I've put that in speaker notes if you need to refer to that. And another side note is with ascites, we need to do a tap. We take out the fluid. That also helps them breathe. That helps them be more comfortable as well. And when we tap, we also look at the proteins inside it. So if you remember this, transudate and exudate, exudate has a lot more protein, and there are different causes for exudate compared to transudate as well. Okay, portal hypertension. So this is one of the complications of liver cirrhosis. Portal hypertension is what happens when we have the liver is so fibrosed, it's so damaged that the blood that's supposed to go back up here and then up further doesn't, and then it has to go back. And when it goes back, it goes into three main places. One, here, esophageal veins, and that causes varices, esophageal varices. Two, the umbilical veins, and that causes caput medusae. And oh my God. Sorry, I just need to sneeze. And three, the rectal veins. So what happens is the blood flows there, and there, and then it engorges the veins, and then they burst. And that's when people have vomiting, and they vomit huge amounts of frank blood, or they have huge amounts of hematochezia. And then, yeah. So how do we treat it? We treat it through TIPS, transjugular, intrahepatic, portosystemic shunt. The way that is helpful is it creates a tunnel here to decrease the pressure in the portal vein, so that we have less backflow of blood to this area, and then you can go back up into the IBC. Liver cancer. So liver cancer, the risk factors are liver cirrhosis and chronic hepatitis, which makes sense because it's just consistent damage to the liver. We need to, let's see, because this is like path relevant. I just can't. Yeah, the only thing like I took away from third year is that liver transplant is the best way of like solving the issue, or like surgical resection. And then it's like people are pretty sick, especially if people have had liver cirrhosis and then liver cancer. You're probably going to need advanced care planning and palliative care. Okay, final topic is gallstones, cholecystitis, cholelithiasis, and choledocholithiasis. The main takeaways are, or what is the difference between these? Okay, these are different from these, but what's the main difference? So this is gallstones in the gallbladder, this infection from the gallstone stuck in the tract. And then this is gallstone stuck in the tract, blocking pancreatic enzymes, causing pancreatitis. And that's what it looks like. AMBOSS has this humongous table. I think this is like really helpful. Just know the main, know Charcot's triad, right upper quadrant pain, fever, jaundice, and Raynaud's triad, plus hypertension and mental status changes. Acute cholangitis, and especially ascending cholangitis, is a medical emergency because you've got obstruction and then you've got a bacterial infection that is moving secondary to the obstruction. It's really bad. Similarly, like another really serious issue, if you remember in the genitourinary system, is when you have renal calculi in the ureter and then like an infection in there. Those are the two cases where it's like anywhere you've got like stasis as well as infection spreading, it's really bad. So what do? We either take out the gallstone, we either do an ERCP after we take out the gallstone if it's in the common bile duct, because remember, if it's stuck in here, then, and that's like choledocholithiasis, then taking this out isn't going to solve the problem. You do want to take it out to prevent further episodes, but like you do need to take it out from here. That's what this is saying. Okay, gallstone questions. So someone with biliary colic is diagnosed with symptomatic gallstones. What do we need to do? Because it's symptomatic, we need to do a lap chole. Open cholecystectomy. This is an open surgery, so we don't really do that. Or they, not me, but it's not really done unless this is not feasible. This is always ideal. And even though someone is like, even if someone had an attack of cholecystitis and then they get better, we still want to do a lap chole anyway because it's going to come back. Okay. All right. And that's done. I to put my GIT history notes there for you to also use. But yeah, thank you so much for tuning in. I'll see you in the question in-person session later. Hope you have a good night.